like diphtheria and all that. We also look at outbreaks that could occur. So that is one very important aspect of infection prevention and control, because if your healthcare workers are not protected, we end up losing healthcare workers, and people will not want to be till healthcare workers start to die, and that is the situation we would like to avoid. So I like before our speaker, I introduce our guest speaker for today, who is Dr. Muzamil Gadania, the National IPC Team Lead. I would like to just get a feel from our participants. Is there anybody that has had any cases, any outbreaks recently at your facility? Kindly unmute and share. Omo Uwage David, you have two devices on. I hope you will not be having an echo. Yes, I'm waiting for interesting shares, because I know that some centers have had diphtheria, some centers have had even Lassa as well, depending on which part of the country. Is someone speaking? I can hear a voice. Nobody has had outbreaks at their facilities. It's not it's not a bad thing to have an outbreak. It's a good thing to even identify that you have an outbreak in the first place. The facility that has managed cases of seeing patients with Lassa or diphtheria, or had outbreaks of multi-drug resistant organisms within the facility. Let me get some.
Mhm. Hello,
You want
good
me to
morning.
start? Yes.
There's a hand up.
Okay,
Good,
Mary, I
good
Abdullah.
afternoon.
explain.
Dr. Abdullah.
Okay.
Yes, good afternoon.
Good afternoon. Go
Good
ahead, please.
afternoon.
Thank you. I'm from Federal Teaching Hospital, Katsina. We
Okay.
It is still ongoing from last year.
All right.
Sometimes we see a high inflow, and then sometimes it just wanes and returns. Even presently, we have two patients in the isolation agency and the World Health Organization, and we've been getting
Okay.
regular supplies of diphtheria antitoxin. We've been managing them well, but we still have two
Okay.
patients currently in the isolation. Thank you.
Okay.
No, we haven't had
All
from
right. So
patients. No,
that's
we haven't
okay.
had. Yeah. Mm.
Okay. So that's good. That means you had good IPC measures in place.
Oh yes, we
When
have. Thank
when
you.
you were mentioning
But
WHO and giving you support, so I think
yeah, thank you.
somebody else had a hand up. Dr. Mary.
I'm on the road, though, so it's noisy. Yeah. You beat it
All right. But at least we can hear you for now. So just
several
chip in
Lassa
what you
fever.
want to say. Okay, you actually had Lassa fever.
Yes. Last
Okay.
year, but not yet
Oh,
this year.
okay. Any healthcare worker infection?
Hello. We also had diphtheria last
Okay.
year.
All right. All right. So you can see that this is actually something that facilities need to be abreast of, so that we are not caught hands down or pants down, as they say. Any other person wants to share? So the rest facilities, no cases. But did anybody identify any outbreaks of multi-drug resistant organisms? Because I can tell you, I will bet my salary that all of us had cases of MDRs in our facilities. Just that probably if nobody says, okay, someone says, Ayo says Kogi is currently responding to Lassa fever. Can you give us an update, Ayo?
Hello, ma. Good morning, ma.
Good morning.
Can you hear me?
Yes, we can hear you clearly.
Okay, I'm Dr. Ayo Oluwatoyin from Kogi State Ministry of Health. So
Okay.
currently, we are responding to Lassa fever in the state. We've had some positive cases from some of our facilities, and I think today about 2 cases still came. And currently, we're on the field on contact tracing. Then I also anchor the IPC part and to see, go to the facility, let's see the IPC measure they put in place. Then some of the very close contacts, we have to put them on the ribavirin and monitor them closely for 21 days. So that is what we are
Oh,
currently doing, ma.
okay, that's good. Well done. So how many facilities are involved? And do you have any cases of healthcare worker infection? Ayo, please, do you have any cases of healthcare worker infection?
No, none currently. The
Okay.
healthcare workers that attended to the person, we are monitoring them closely.
For
Prophylaxis.
prophylaxis. Okay, so that's good. So we want to avoid healthcare worker infection as much as is possible. There was a chat I saw coming up. Let me see. Okay, all the chats. Okay, Kugi is currently responding. Somebody says, Ishaya says we haven't gotten Lassa or diphtheria. So, okay, I was also asking that any cases of multi-drug resistant organism outbreak in that will not have had cases of multi-drug resistant organisms among patients.
Hello, good morning.
Yes, good morning, Hafiz.
Yes, in the case of multi-drug resistance, pediatrics ward as well as SCBU, where we have
Okay,
case of multi-drug resistant Klebsiella.
yeah.
I'm talking from ATBU Teaching Hospital about.
Okay, Bauchi. Okay.
Yeah.
So it's good cases of MDR because just as I said, there's no facility here. I said anybody that wants to prove me wrong, go and check your records. I'll give you my salary for the month.
Ma, I'm
That
here.
sorry, ma'am. I can bet that you have had cases of MDR, just that you are probably not following up. There's no surveillance system to detect. So
Yep.
I think my chief is already on the call. Program lead, and he's also the incident manager for diphtheria EOC. Please let's make welcome Dr. Muzamil Gadania. Yeah, welcome, sir. The stage is yours. Sir, do you have slides to share?
Permission to share. Okay. So can you see my screen?
Yes, we can.
All
We
right,
can just
good.
put it in present. Okay, fine. That's fine.
All right. So thank you. Good afternoon. And sorry that I joined this late. I remember I made a promise to my boss, Dr. John, that I'll be here to have this done. So here I am, and thank you very much for your patience. So we are going to this EPR, outbreak investigation and management, because some of these things are realities, especially within our settings, at the facility level. How outbreaks is beyond just the priority diseases, but also some priority pathogens that we do have across facilities. As a country, we have a list of our priority pathogens based on our AMR surveillance guideline. So based on those priority pathogens, via the lab, that we are able to have those reported. So just like we have that, the list of priority diseases based on IDSR, we also do have these priority pathogens. And the priority pathogens also is arrived at following some exhaustive systematic process that took cognizance of data and expert opinion like all of you that are on this call. So I take it all of us are from facilities, isn't it? Okay. Or is there any person that operates at the level of the state?
Okay, and
State.
that's
Who?
Yes.
Sorry? Sorry, I need to have an understanding. Who? Who? Which state?
Yes, I'm Dr. Mohammed, Kwara State.
Ah,
Yes, sir.
Abiyesi. Good afternoon, sir.
Afternoon,
Good,
sir. Thank you, sir.
good that you are here. Good that you are here. Fantastic.
I'm from state, sir, Kogi State.
Oh, Dr. Ayo, you're everywhere at these rates. You are like Kante, right? You cover everywhere. But it's good to see you, and such commitment that you've shown together with colleagues, of course, Dr. Mohammed included, of being consistently seen in places that CDC some respite, to understand that if we continue to see consistent names and consistent faces across different platforms and meetings on IPC related issues, it means somehow we are established upon us per se compared to what we used to have. Prior to now, if you call for 10 IPC meetings in a state, you see 10 different faces. But right now, you can call for 10 meetings at the state level and you see the same face. Somewhere are making deliberate efforts to see that these structures are actually supported to be functional. So it's good to have you, and the perspective you bring as state focal persons, I think, is is going to be very interesting to this discourse. Also get to hear from your side of the story. So, but like I mentioned, the discussion here per se, the sense I got was that majority of people are facility based, so we may not need to go diseases in the full-blown public health pathway per se, but rather we can lay more emphasis or put more energy on the facility side of things in terms of HI and common principles you can draw from the public health emergency management to this one that you are dealing with for healthcare facilities. So apologies ahead of time if the discussion or the slides are more tilted towards facility. Audience that inform that. But of course, during the discussion periods, if there are priority diseases that continue to bug you in terms of your state, we'll be happy to discuss them. Their preparedness, readiness, and response efforts from the IPC side of things. We'll be happy to take that also. But like I mentioned, the principles are actually understand key definitions that apply in outbreak settings, especially in a healthcare facility, and discuss the steps, for the outbreak investigation in healthcare facility. And then also, what are some of those management steps that you need to do? And of course, we also want distance, the didactic presentation are things that you can certainly pick up, anything I read and you will know more about them. But then certainly what this is like NSIC is the fact that they have the convening power to bring subject matter experts together with colleagues on one platform and have a common discussion on that important problem. So for me, it's actually a very, very unique actually noticed within the IPC space. So thanks to NSIC, thanks to APIN for convening this, and certainly to practice IPC across different levels, and of course, for coming together on such a platform to the likes of Dr. Showande and other patrons of APIN, of NSIC, my boss, Dr. John. This is really we have began the discussion. Healthcare infections will be the center of our discussion. Or hospital-acquired infections, and they are defined as an infection that is occurring in a patient that is, obtained usually through the process of care, which was not present or incubating at the time of the admission. So when the patient came, or rather, it even happened following the things you directly did. So either way, a timeline or a mark of 48 hours or more after admission is actually considered for HAI's definition. It means anything that happened much, longer before that time. It includes infections that are acquired in hospital, but then they often come later after discharge. So those are prospective infections that do come, and those ones so that must be highlighted is they include infections among healthcare workers, among staff. So if you have Lassa fever healthcare worker infection, like we have recorded, acknowledge that that is part of healthcare associated infections. Again, so something we like to talk about within epidemiology is the concept of the epitriad that come together in making sure this happens in terms of HAI. So, and then also you have to have that susceptible person in terms of an unsuspecting patient or healthcare worker, as the discussion we have had earlier, that infection among healthcare workers also is termed as HAI. There, which may be the patient or the healthcare worker himself, and then to the next unsuspecting person. So when you have this coming together and uh, the equilibrium is not distorted, that is when you have factors, certainly. So that must be also viewed together with other things. Factors associated with HAI transmission, especially in a setting like ours, are inadequate to wash infrastructure and supplies. Water, sanitation, and hygiene is actually the primary healthcare facilities in your state. You will see that probably, I don't know which state many of you are operating in, but you see that a good number, up to the last publication I saw in Niger, up to about 40% such, and they were able to partner with other agencies, including MPHCDA and NCDC. And you can imagine, so it means about half, of the facilities that were sampled do not actually have that water on the premises of that facility. Go far place, fetch it, or even the patient, get that themselves and bring it. So again, if you look at this, then you know that it's a recipe for disaster that could happen in this setting, which is HAIs. Environmental hygiene in terms of cleanliness, is very important. So if that does not a good petri dish for pathogens to thrive, and then before you know it, they can be transmitted. Understaffing leads to overworking, very much related. So when you're understaffed and overworked, it means you're more all of us have personal stories of how some of these things, could have affected or continue to affect us, So I remember a personal story. When I was doing a house job somewhere in one of the hospitals, somehow the EUCR bottle, I think, slipped into a sharps container. Yeah, sharps container. And frankly, I wanted to put my hand and get it. Yes, I wanted to do that, but I was so sleepy. I was so tired. That was like 48-hour back-to-back call, stretch. The matron in charge, who was a male nurse, I still remember, it was male medical ward, almost yelled at me like, "Do you know what you're doing? Are you normal? Are you okay?" Say, "What happened?" He said, You don't do this. You cannot. In fact, you shouldn't do this." Considering certainly I was tired, and then I just wanted to get that done. So of course, that was a position that probably if I had rested and if I was, I was not that stretched, probably I would not have been able to put myself in such a situation. So that is where the work happen there, and then you count that as HI. Overcrowding, certainly, because hospital is a unique setting where you have assemblage of people coming. So you by virtue of that, many different people come with different that exists there in some of the facilities in terms of space and environmental cleaning and wash facilities and whatever. All of them will be overburdened. And then you begin to see some compromise in standards of cleanliness and standards of disinfection. And then even in air in itself, the air that gets circulated there. So all of this suboptimal knowledge in IPC and skill. If you're knowledgeable about IPC, the expectation is knowledge should lead to, better practice. But it's not always the case, certainly. You have people being knowledgeable and then their practices are not informed by that knowledge. So that again signifies to you how hard behavior changes. When you do not have documented guidelines that states how some of these things should be done, then you also run the risk of having HAIs, and policies that state that there should be there will be functional IPC programs in a facility and that it should exist with the details, the facility level of risk, and also the status they have found themselves IPC wise and how they want to move from there. Later, we'll come to see some of the preparedness efforts that should be inherent in the system to make sure HI is not exhaustive. But if you focus on this 5, I think you'll be doing very well for your facilities. BSI, central line associated, bloodstream infections, and then also VAP, and then also CAUTI. Preparedness systems for HAI prevention. So you need to also condition your mind that since HAIs are things that you do not want in your system, right? So you may not be able to, or they do not happen at 0, right? But you can certainly reduce them to a level that they are no more burdensome. And the only way you do that is if you have some of these systemic functional IPC programs. When you have functional IPC programs, is the foundation for getting it right. Because programs or functionality of IPC program is what will entail that line in place. And then more importantly, also, there is a budget line that is used in implementing priority activities that have been identified in that setting. So all of these can only happen within the ambit of a program. Early warning system, EWAS, we call it at the NCDC. So the only way you know something is not happening is if you keep an eye on that thing, right? If you don't count, if you don't monitor it, then you may not know whether it's happening, which is the system that you have built. So it's important you are deliberate, in how you go out to actively look for these things. If you look for it, you will very much see it. Like Dr. Joan mentioned earlier, that she is very sure that a HAI is occurring in your facilities. But just because of some, they are accounted for, they are also, there are systems in place to count them and then make sure that some effort is done to actually prevent them. Then you are actually not have these functional HI programs, HI surveillance in the facility. And you can certainly have alert thresholds that you set in the lab, based on the early warning system, that, okay, if you see, but if you see certain number, maybe over some period of time, then it's a problem also. I remember in one of the tertiary healthcare facilities, one of the first times the NCDC responded to HAI outbreak, infection outbreak, in a healthcare facility. And that is the level of expertise we aspire, especially for the state focal persons to reach, to be that confident, to be that systematic that you within your state, to see that when facilities face such problems, they can invite you together with some other partners as subject matter experts, and you can go in, render your expertise and service, and then see how you work together to put the out and then work together with the team to have it stopped and then have it investigated. More importantly, again, you could not have done all of this without some functional IPC program being in place, because it's when you people responsible for counting these numbers. And if this social organism is seen, this person must be informed. So it's only when you have a program that you talks about the therapeutic agents that are used in healthcare facilities for any of the antibiotics, antifungal. So all of this, there needs to be some systematic effort to make sure that prescriptions are not just written based on doctor's hunch that is used by the doctor in the OPD or wherever it is. Yeah, there should be a drug formulary that is actually informed by surveillance data from AMR based on that look. The antibiogram tells you that, okay, for this place, we see this particular pathogen, Klebsiella pneumoniae, and this is what is termed as the treatment, and ABC are resistant in this place. So it means giant hospitals can continue to shine the light where there are dark spaces. That's why we have teaching hospitals. And then other secondary care facilities, they can adopt the antibiogram from that place because they operate in the same locality. What is seen within some certain geographical area, you will have some degree of state, the organisms are all, similar because the people that occupy that place are actually similar. So you can make that assumption, and knowing that certainly you are using what you consider to be a proxy your facility. So in the case that you are not able to do that for your facility, a proxy one you can use is that one. So it should be guided. And that thing says, okay, you use this for this duration and you are able these antimicrobials as much as possible. Don't make decisions for patients. And that's where I personally have problem, especially with most of our colleagues. You just assume some of these patients can do these things. They won't do lab work. You just say, oh, probably could appear unassuming, but he has plenty cows in village, I promise you. And if you really sit them down to have a talk and then really do it. The common example is blood cultures that are done. You just assume patient cannot afford blood culture, and then you just go ahead and blindly shooting on dark spots. It's not helping the system, and it's certainly not helping us. It's not helping. And they will be able to bring it for you to do what is needed, what is best for you, what is safer for the patient, and what is best for the system. Monitoring of standard precautions, very important. If you do that as part of facility-based IPC program, these abnormalities. And then also other IPC processes that are closely associated with that, including structural processes or indicators in that facility. All of this can be done with the mindset of infrastructure certainly provides the base or the bedrock, rather, for all of these things I mentioned to thrive. Of course, these are just the key preparedness systems that we HAIs are kept in check, or in some instances, even when they occur, they do not result to a full-blown outbreak. So which leads us to this slide. What is an outbreak? So if outbreak happens, what is it? How do you qualify it? So an outbreak is defined as an increase in occurrence of HAIs above what is expected in that population, in that area, over a particular biological reasons, time, place, and persons. Number of persons has to be exceeded, and then in that place, and then also for that duration of time. That establish background rate, very important. There are states that if they have one case of Lassa fever, will be considered an outbreak by the NCDC. The EOC is not even opened because as far as their minimum level of outbreak threshold is concerned, it's actually an outbreak, that would warrant the Commissioner of Health coming on air to address the press. But Edo State, no, they're still chilling. They're going to market and everything is happening. Of course, there are watch staff in the UOC doing the needful, but it's not at a level where they will have to convince subject matter experts and then be able to see how they can tag the incident. On rare occasions or occurrence, many episodes of a common occurrence can also be counted as that. So epidemic their geographical area, so you can have outbreak in a locality, but then also, if multiple states are actually the epidemic threshold here. And then also clusters, aggregation of cases in a given area over a particular period without regard to whether the number of cases is more than expected. Some are true related diseases. So again, you could have pockets here of cluster of cases, but it may not really be at that level, or it may not, occur within that duration that you could qualify it as of cases. Right. So there is here for us an exercise to do. Which of the following situations can be an outbreak? So I will need you to probably unmute and tell me after we have read it. Develop pneumonia after admission to the general medical wards. B, one patient in the surgical ward develops purulent discharge on the surgical site. In fact, surgical site incision, terminal wound dehiscence after CS within 2 weeks. And then also the last one, 2 cases of varicella in pediatric ICU within 5 days. Any takers? This is meant to be interactive, please. So as much as possible, I would
Option
urge you to-
D,
Sorry?
the
You
last.
We can give you permission to speak. So nobody would like to attempt this? Okay. Precious.
as well. So
Yeah,
both
yeah.
of you can.
Same person.
Yes, ma'am. For me, I go with the last option. 2 cases of varicella in the pediatric ICU within 5 days.
Okay. So that is the one that can be considered.
Considered an outbreak.
Hmm? Hello?
I think Doshima, your hand was up as well. Let me check the chat.
The same person.
I
People
can
of
see
God, people.
C and D,
I want to
C
see
and D,
hands
C and
coming up now. All of you are experts now. Most
two
of you have
hands
done
are
the
up. Two hands
uh
are up.
Please, so go ahead. Hussein Oyetunji.
Good afternoon, sir.
Which of these situations can be considered an outbreak?
I will not consider anyone. I want to consider the relative population of the patients that are inside the ICU.
Unfortunately, you are limited by what you see, so you must choose.
Okay, I will
You
take
are
C. The number of people that are involved based all the time. But nevertheless, the thing is not to compare the number of incidents relatively to the prevalence. So that one will tell us how what the outbreak is. So that is my
saying. You are making many assumptions and also overcomplicating the matter that is simplified for you. This thing is simplified for you. They ask you just among this A to D, which of the following situations can be an outbreak? Chicken. You understand? Don't bring any foreign assumption. But I understand knowledgeable people like you that are professors. Ali Ahmed.
Option C.
Okay. This can be considered an
Yes.
Is the network from my side?
Yeah, the same thing. He's breaking up.
Okay. Okay. I think he's off now. Network issues, I'm sure. So let's just give him a few. The chat. C is the answer. The answer is D, C and D, C and D. It's like we have more votes for C. But what did the question say? They say which of these? Does it mean it could only be one? About outbreaks, about clusters, about surgical site infections. Maybe we can rethink some of the answers. Let me reach out to him and get back. Are the options? I don't know. If the presenter has been knocked out by network, I'm just trying to reach him on phone to see if we can get him back in. We talked about surgical site infection. Some cases occurred after surgery. Some cases occurred. Said infections occurring after 48 hours on admission that was not present before the patient was admitted. So if you have that at the back of your mind, can you take a look again at the options that we are giving? To mute so I can reach out to him on phone. Thank you and over for now.
Hello, sorry, I had some network interruptions, but I'm back.
Okay, welcome back. We are discussing.
Thank you. Can you see my screen? Yeah. So I right. I'm not sure. Ali Ahmed raised his hand, but I'm not sure what he said. Goodness. Hi. Yeah. Hello?
Yes, we can hear you.
Go ahead now. Give me the answer. Supply the answer. Okay. So I think we can discuss it, right? If you want us to do that. But from the point of view of IPC, I think option A is patients that have had this. You can't say it's an outbreak. Certainly, you can say it's HAI, but is it an outbreak? Then that's a different thing, isn't it? And then also, one patient in the surgical ward develops purulent discharge. That's a HAI. Hello?
Yes, sir.
Yeah.
Yeah, good. So, but
Yes,
certainly, if you look at a C, C spoke about 10 women developing SSI. Postpartum women develop abdominal wound dehiscence after CS. And time there. And then also it brings the number under concern as to what could have been happening in that theater or the IPC processes in that place as far as it is concerned. So you could make a case for this, but certainly or what you can consider HAIs, sorry, outbreaks, because in a healthcare facility setting, when you have a single case of varicella even, it can be considered, an outbreak, especially in pediatric ICU. So this, occurred twice. Choose and grade them based on maybe in terms of pecking order, I would say D, then C. So this, for me, they stand out and they could certainly qualify as that. I hope it makes sense. Does it?
Yes, sir.
All right. Why should we investigate outbreaks? Why do you think we should investigate outbreaks? Abdulhamid Lawal, can you tell me why we should investigate outbreaks? Why do you think we should investigate them? Very quickly, please. Or is it plug and play you're doing, Abdulhamid Lawal? You just plug it like you're on the stuff and then you go about doing your business. Anyway. Adewale. Okay.
Hello, sir.
Yeah, who's speaking?
Abdullahi Musa Kenya. So the reason why, sir, the reason why to identify the index, the source of this the infection, which may be an outbreak in the society.
All right, good. Very good. So what else? You speak, please. Mhm. Grace. Okay. Do you want to speak? You came off mute. Rashid. Abdul Rashid.
Hello,
Yes, sir.
hello, this is Caroline. So as to be able to know the pattern,
Right. Why do we
Okay,
investigate?
sir.
to be able to know the pattern of the
I got
outbreak.
you.
This is
Okay.
Caroline.
All right. Thank you, Caroline. Yeah, Rashid,
Want
go
to
ahead.
want to know the organism responsible.
Mm-hmm.
We want to design a strategy for the control of the outbreak.
Very good.
Again, we and
Yeah.
probably design how we are going to intervene.
Very important.
Again, to
Mm-hmm.
keep the record. Also
Yeah.
want to keep the record.
Yeah.
Thank you, sir.
Yeah. Thank you. Those are actually very true. Yes. Something is happening amongst people, and there is a government in charge, or there are authorities in charge. For the sake of accountability, they need to investigate what's happening and be able to make the report known to people. So advise that of what they should do or shouldn't do, and how even that can change policies and what have you going forward. So this again is very much true. All that are highlighted here and beyond. Right. So also steps for outbreak investigation, if you could just go over them. I know this is bread and butter, especially for the public health physicians and public health guys amongst you. So what is the first step in an outbreak investigation? What do you call it? Short essay questions. Yes. Or you're doing any of the exams. Just, rattle down, or you say them. They're supposed to be at spinal level, right? What is the first step in outbreak
Is
investigation?
sample collection, sir.
Interesting. Thank you. Even if it is looking at you on the screen, I deliberately left it there so that at least it can help you, isn't it? If you're going on a journey, what is the first thing you do? You're coming to Sokoto from Kebbi, thank you. You need to first identify how you're going to do that, commute. And resources that you need for that process. Are you not going to check fuel level? Where will you even get it if you don't have it? All of these are things that you will check. The Yamayama police or Yamayama doctor, and they have brought you in to look and then see how you can identify the culprit. So it's like a police work. It's a detective work. Mostly you are doing the work, or you are trying to retrace your steps back to be able to establish QED. So first, of course, as an overview, is you want to identify the investigation team and resources, and then you want to first establish, yes, this outbreak is true, that there is actually an outbreak. And then you verify the diagnosis, find cases, and develop a line list, right? And then also you also need to keep in view, if there are contacts, you also need to do contact line listing. Perform descriptive what could be causing what. So you need to look at that and then evaluate hypothesis, perform additional studies as necessary. Then you do implementation of control measures, because the reason why you are doing all that you are doing is that so that more people are not affected and less people die from that thing, right? They also need to make sure you maintain surveillance so that if there is any change or the occurrence, you'll be able to know. So this is very important. So I think very quickly going through some of this, we just breeze through them, knowing that you know them, identify an outbreak investigation team. So if a reported case of Lassa is reported, we'll put together a team to do an outbreak investigation. So part of what will be required again in a hospital, once an outbreak is suspected, notify appropriate individuals, department, the institutions. So here, the IPC focal person of the facility must be informed, and he will come with his team to be able A3 mapping to see how they will go in to investigate the outbreak. You need to establish an outbreak investigation team with clarity. There is a team lead, and then also it's a diverse team with people with multiple skills. Some are epidemiologists, some are clinicians, others are nurses, and then some of them are statisticians, IT oriented. So when you have such a team, then the team is diverse, right? Identify available resources that will be needed, man, money, material that will be needed. Just as a suggestion. So again, you need to confirm that this problem is actually true. And how you do that is, of course, gathering preliminary information. Microbiology data, if it is available, and then you peruse some clinical notes to understand severity of that problem also. And then also you try to link that up with some demographical data. Where are all these people? The concept of TPP, or rather P&T here, place and time. So they are all coming from somewhere, and these things happen all within a short period of time. So it tells you that this is likely maybe a poinsettia epidemic or something like that. So it can also need to make sure that even though you have confirmed the outbreak, that it has happened, you need to verify the diagnosis that have been made, because one of the easiest things to do is to actually condemn the goat so that you can hang it. You just give really dangerous, that you just say in the case of, let's say, malaria, and say you are suspecting Lassa, and you write inside that clinical note. You know how you have condemned that patient? It means and the courageous are not around, that patient will probably opt himself out of the hospital. I.e., what I'm trying to say is probably nobody will attend to the person. I've seen this happen, to the extent that the patient relatives, some of them who work in the hospital are saying, this is not Ebola. They say, no, it's Ebola. We are not touching this guy. Sad, but these are existing realities that happen. So you need to review existing data, medical record charts, surveillance records, microbiology, all sources of information within the healthcare facility as far as that case is concerned. And then you need to interview a few, important staff that maybe were there before you and have been involved in the case management. So you, as the team that are coming to do the investigation, you need to all take into cognizance distance. And then also you need to, of course, conduct further investigations in terms of testing, if you need to do it yourself. So all of these things are things that once you talk to people, review data and see gaps, then you can begin to see how you fill in the gaps here. So you at first develop a case definition. And then usually the one we advise is the tiered case definition. You can't make it so specific to the extent that the sensitivity aspect of it is ignored. And then also you can't make it so sensitive to the extent that the sensitivity, the specificity aspect of it is ignored. So you need to take into cognizance both of them so that you are able to strike a balance. A case definition is a set of standard criteria for classifying whether a person has a particular disease, right? Decide what constitutes a case. You need to do that. And then what is a suspected case? What is a confirmed case? What is a probable case, right? All of this is important. And then also narrow enough to focus efforts, but broad enough to catch all the cases. So you need to consider that the concept of TPP, time, place, and person. So if you are formulating a case definition, you often will want to not just make it a clinical thing that, okay, everybody with this sign and symptom. No. Oftentimes you also add the epidemiological aspect. Okay, any person with such sign and symptom, especially if also they have been to ABC or somebody who has been to such a place. So in the early phase of the outbreak, you want to use this religiously. But then as the outbreak evolves and then maybe there is sustained community transmission, it may not be feasible to actually maintain this. So you just blow it open and then it will be any person with such symptomatology or presentation, and that will qualify because already there is evidence of ongoing and sustained community transmission. A gradient definition based on level of evidence, suspected, probable, definitive, confirmed is often helpful, as we do for most of these diseases. Use previously published the CDC together with the Health Safety Network in the US have actually thoroughly investigated some of these hospital-based outbreaks, and they have been able to document some of these cases. You have fits into such a documentation. Why not available? Use standardized written case definitions to ensure precise surveillance. The WHO also use the same definitions accurately over a period of time and consistently. So once you do that over time, you will gather critical data that you can even validate or invalidate that your case definition. So rigor. And once you do that, you should be able to have that established or published as a standard protocol, challenging mainstream established evidence and what have you. Again, also BSI, that also we can clearly differentiate, for ourselves, right? Primary BSI can be lab confirmed BSI, LCBI, that are not secondary to an infection at another body site, right? And then also you have for that also you want to look at the LCBI where central line or umbilical catheter was in place for greater than 2 days on the event date. And we will later find out what event date is, but I do know some of you do know that. So is was in place on the day or the event date the day before. So this is important because what this last part tries to actually ensure is that that you have the occurrence happening for greater than 2 days or the event happening for greater than 2 days. Placement being day one, and the line was placed was also in place on the date of event or the date before. So it has to be that it was put on that day or the day before, other parts out. So for VAP, which is ventilator associated pneumonia, by you identify that using a combination of imaging. One of which is X-ray, certainly chest X-ray. And then also you can do some history. You can do, what do you call it? Some of the bronchoalveolar lavage and what have you that are done. Also the villi brush or ciliary level see on this part of the world. But certainly for what is done is just a CT. If you do a CT within the PPS that we do in NCDC, or some chest X-ray is able to document that this serially is what is termed as is on mechanical ventilation for greater than 2 days on the day of the event, with the day of ventilator placement being day one, and the ventilator was in place on the that day or the day before, and then the day of the event being day one. Sorry, the day of the ventilator placement or the catheter placement there also being day one here. So there is also non-couch. These are common HAIs that we have occurring in our setting. Out of those 5 that we have highlighted earlier, patient has at least one of the following. That is fever, tenderness established there. And then also when you check the urine, you have more than 2 species, of organisms identified, one of which is a bacterium of 10 raised to power 5, colony forming symptomatology that is adding up together with the urine MCS, then you can actually say, okay, this is just, a UTI. And certainly CAUTI in itself, that a UTI where an indwelling device is in. But then there is a documented risk factor there, which is the indwelling catheter, was in place for greater than 2 days or the day before, and patient has a clinical signs and brain culture with no more than 2 species of organisms, one of which is a bacterium of at least 10 raised to power 5. So that 10 raised to power 5, per many of the protocols you will check, you see that that is the level that is considered significant. Manifestation that you're having, and then that could qualify as a UTI. I think the classical difference is the obvious risk factor that is in the CAUTI, which is actually not in the non-CAUTI person. Systematically find these cases and then develop a line list. Line list, of course, is nothing but just an Excel or a Word or whatever it is you choose to use with some variables that are of epidemiological relevance. Patients. So you can do it for cases and you can do it for contacts. And this is shown here, how you develop a line list. Many of you are experts in this, so I may not have to worry you, but certainly. Then also, if you are to share it, you would have to redact some of these things and then make sure these things are not shown for data sharing agreements. And then also it has important by data like age, sex, so this is a sample line list that was used in Boston. So this, again, you can see it also took cognizance into time of meal, when was the patient last fed, and when is the date of onset of symptoms here, and then also time. everything that's available in the menu of the hospital is here, and then whether the patient had it or not, that is shown there. So again, perform descriptive epidemiology and develop hypothesis. Describing what you are seeing. That is typical descriptive epidemiology. And then also, you are hypothesizing based on the records that you have reviewed, lab-wise, micro. Say, okay, very likely this is the source where this outbreak could have come from. And then these are the guys that we are thinking. And then, of course, the final pieces will come together from lab to confirm. Also, you would have you may be required to actually take samples, environmental samples across surfaces, common areas between the patient and staff or other patients. So all of these places, you make sure you sort of sample them to look wide enough, but then not very wide, so that you are able to very much also formulate hypotheses to explain observed incidents that you're seeing, and then you can explore further associations. If you want to do expert epidemiological service, then this also can be done. You can do some retrospective cohort study, or also, certainly go and do. And then also identify the source of the infection. So also, you want to evaluate the hypothesis further so that you are able to strongly arrive at that last bus stop. Test hypothesis about relationship between diseases. If you are exploring gastroenteritis, then surfaces, or some of the places you want to maybe narrow your energy to, surfaces within the hospital, and looking for organisms that potentially could cause GI manifestation. So C. difficile is very much an important, example of such organisms. And then also, to further buttress the descriptive epidemiological description that you did, that's when I mentioned that you can do some, study designs, however you want to do it very quickly, to just ensure that it is able to sort of narrow down on that. And also, it further validates the epidemiological description that you have done, so that you are actually guided by two levels of fact rather than just one level of fact. And then also determine the appropriate approach to surveillance depending on the issue being surveyed, depending on what it should be at that point in time. Right? So for you to do that, you need to implement control measures. So all of you as IPC resource persons, you know what to do. Some instances you isolate cohort together, or you do them in solo, and then also you can withdraw all of that, and then also as much as possible, see how you balance between preventing further diseases and also protecting the credibility and reputation of the institution you work at. So as much as possible, and make sure that the public interest somehow is accounted for in that regard. This should be guided by epidemiological results in conjunction with environmental investigation. I made mention that you sample the environment. So what you're seeing on the environment, is it in keeping with what you saw in some of the patients? So if it tells you that, then fine. Then you can further go to do some nested case control studies. to look at the issues in isolation, and then more. Some general IPC measures, which you are all experts in, things that can be done to actually halt transmission. It's hand hygiene. You must make sure that is enforced across everywhere. Also, standard precautions, as they used to be called, universal precautions, isolate of contact, droplet, and airborne. But then, of course, for these ones, you will deploy them when you know what you're dealing with. Once you establish the culprit and you know the mode of transmission of the culprit, then you can deploy these isolation level precautions. And then also environmental cleaning and disinfection, sterilization of medical equipment. Possibly you want to do training. Training is one of the important modalities for preventing HAIs, because when you train somebody, then they know how to safely work. That's the assumption you are making. And you're hoping the assumption that knowledge will translate to adequate staff levels so that staff are not overworked. You communicate findings. You don't say until I finish, then I will say it. You can preliminarily tell people what you have found. Strategic communication. When you do FEM or when you do FETP and whatever, you must be taught how to communicate in crisis. During crisis, you don't wait and say until we have everything, then we come and speak to the public. No, you speak to them, intermittently, but most importantly, be very factual and do not say the emphasis that this is what you know now, but of course, these facts could change. And if they emerge and change further, you will be back with fresh update. So once you are able to keep that side of the bargain, people will have some level of trust in what you do. But when you don't communicate, you just stay and the problem keeps eating people. That you don't want in any way. So as much as possible, you want that. And then also the media attention would feed into what you do. So it's important you also are trained to speak to the media. Just because you're an SME on a matter, I don't think it to speak. If the agency gives you the authority to speak on its behalf, then you can go ahead and do that. But if that is not given, please allow this, make the facts available. You may not be trained in this. There is a public relation officer of the hospital, a PIO, or somebody even within management position that has expertise in risk communication and community engagement. And importantly, in crisis communication. So you can, and then they will know how to put it in a story form that will appeal to the public. So you must have the authority and you must be trained to actually speak to the media. If not, you can undo every. So not being confident in what you are saying. And then the whole thing could be thrown something that is not factual. Right. So you want to avoid that. And then also you write your final reports based on, the findings that you've been able to arrive at. Lab and microbiology data, including interviews that you have conducted. All of this should lead you to somewhere where you say, this is the guy that caused it, and this is the source of this thing, and this is how it started. Right. So you it's very important. It's very likely that such a problem will come and then reoccur without you knowing. So you need to maintain that. So I think in conclusion, we've been able to establish the epidemiological investigations. And distance, you must be systematic and you consider each step within the 10 steps that we have described. Follow the steps if appropriate, but nobody says you must follow them sequentially like that. Of course, you can start somewhere and then stop and then even repeat. Multiple steps, establishing a team, you are mobilizing resources, and you are trying to confirm the outbreak. And while you are doing all of that, you are interviewing people. So it doesn't mean that it's from 1 to 2 to 3 sequentially like that. And the last thing I will end with, I think, is to also, or rather, I think there are a few management of the outbreak, so preparation and prevention. You want to make sure IPC programs are in place, staffing levels are optimal, there are surveillance systems, like I mentioned earlier, and then also detection and diagnosis. You want to make sure there is early microbiology testing. You should have the capacity in terms of equipment, material, and test menu to do that. Outbreak response, you should do actions so that it stops spreading. Isolate cases, and then you trace contacts. Control measures, again, AMS programs, IPC programs, all this. Internal stakeholders and then external stakeholders. Monitoring and evaluation, how you do that is, of course, you've halted the transmission of this particular pathogen. So you need to keep an eye on it and then make sure that you are able to know when the situation changes. And then also, every outbreak is an opportunity to learn something. As epidemiologists, learn from it. If you don't learn from any outbreak that happened in your setting, be it a state, a facility, then it's an outbreak that is it's a missed opportunity, actually. So again, start wellness system that take into cognizance the mental health of your staff. These are common issues that happen post-COVID. So like I said, the last thing I will mention on to management of outbreaks, be it largely in the community setting, and then but can be also deployed in the facility-based setting, is the use of the incident management system. This is latest. This is it ensures the whole of system approach in dealing with that problem, and then it ensures resource mobilization, and then allows you to operate within a setting that is just command and control as we do. You would have one or two things you want to ask or one or two things you want to add, because you yourselves, you are experts in your all right, and these are things that I'm sure in some way you would have participated in such a love to hear from you. I would love to learn from you, especially if you have done outbreak response in a healthcare facility. It means HAI outbreak, in a healthcare facility, and you were part of that response, and then see if we have any hand up. Okay, anybody with anything to share, especially facility-based outbreak response? Okay, nobody has responded to our outbreak in a healthcare facility. Okay, so how about hello? Hello? Am I audible? Can you guys hear me?
Yes, we can
Yes.
hear you. So do anybody have questions, contribution? Okay, someone's hand is up. Ayo. I could see your hand. I think you've taken it down. Are you still on the call, Ayo?
Yes, I'm here.
Okay, please go ahead.
Please,
Okay, good afternoon, sir.
okay, go ahead, please. Okay,
And
so
it's
what have you
actually on
learned?
Lassa fever. Huh?
Lassa, what have you learned that is worth sharing on this platform?
I think the way you mentioned it is actually how it was done, because I think NCDC had to come, and the first thing, which one is on IPC, case management, and which role everybody was going to play on the field. Then we all
Okay.
departed to the field and we identified the facility. So
Okay.
actually the index case was dead. So we had occupation and what the person was doing and the close contacts to the person. So those were the things. So from there, we're able to reach other contact. Then the facility itself, we had to identify the staff that attended to the person. Well,
Okay.
was he at any other facility before he got there? So
Super. Is it this current outbreak or the last year's one?
last year's one and even current one, the NCDC didn't come, but we just took the step they took when they came last year and we replicated it this year.
Okay. NCDC didn't come to Kogi this year?
No, they were.
Well.
Yeah.
Okay, thank you very much, Dr. Mozembe, for the very eloquent presentation. And talking about the outbreak, presently, in Kwara State, we have imported Lassa from Ogun State. So, and what we did was, even though the patient is late, we're able to take some samples, very high index of suspicion from the facility, and it's a tertiary and the community. We've been able to communicate with. Am I being audible?
It's breaking though.
Yes, but it's breaking.
So, anyhow, we've been able to combine both the response within the facility.
Go ahead, Dr. Mohammed.
Okay.
Go ahead.
We've been able to respond both at the community and at the same time at the facility. The medical doctors and the other health workers that are involved, their samples were taken.
Yes,
and prophylaxis were given to them.
The webinar I should be done in like 5 minutes.
And we communicated same to the Ogun State group. So presently, we are mapping out training on other facilities within the state, especially those high flow facilities with high flow, and that they can receive patients from PPEs and education backing. So that's what we're doing. And of course, we have the surveillance officer from NCDC with us. She is always with us. Thank you.
Okay, fantastic. Thank you very much, Dr. Mohammed. Outbreak. It's good to actually know that there are trained, competent people in settings across the national and subnational, and it gives us, that level of confidence to continue doing what we are doing, knowing because without experts or subject matter experts like all of you that are here, we will not be able to actually do that. So thank you very much. Yeah.
Rashid, please, you want to say something? Your hand was up. Okay, Dr. Mary.
Speaking already.
Okay,
Okay, good afternoon. Good afternoon, everyone. Thank you very much, Dr. Muzamil, for your lucid presentation as always. Of course, we've had it in the past, like I mentioned, we've had Lassa. Last year we had Lassa outbreak. We also had diphtheria, and like Dr. John like Dr. John mentioned, now and then we have MDR outbreaks. So, but this is the Lassa season.
Yeah.
So we have not yet had a confirmed case, but we have had alerts.
Okay.
So, as focal person, what I have done so far,
In the facility.
I put out, yes, in the facility, an alert message initially, like 2 weeks ago. And then this week, AMS and Outbreak. So just on Monday, I had a training, a multidisciplinary training for the IPC, the newly constituted IPC EMS and Outbreak Committee, the IDU team training, and then there are action points for us to carry out. One very important one is setting up triage stations. We're working on those, and then flow
Across
charts,
the point of entry, right?
checklists.
Yeah.
Yes,
Good.
yes, the key points: GOPD, A&E, CHO,
Okay.
and labor ward. Those are the ones we SOPs, flow charts, and all of that. And then the next move, hopefully, in the next 1 or 2 weeks, is to see how we can have a hospital-wide sensitization. We
Okay,
did
no
that
problem.
last year virtually. We hope to be able to do it, but only if there's a representative from the A&E in our committee. So that's what's happening in UPTH. Over and thank you.
Thank you very much. Thank you very much. Good to know that, again, UPTH is stepping up, courtesy of the Mary Alex Wille. Thank you very much. It's actually good to know that you are there and you're pushing from that angle and you're supporting the state in that regard. Thank you. So, any other, healthcare worker infections among among healthcare workers for Lassa fever. So I just want, if I can get some quick signs other colleagues are protected, following the incident that happened. Tina from Jute, is it possible you unmute and speak on this?
From our own end, I wanted to actually raise my hand for an outbreak investigation for HAI in the facility and what we did. So before I go to the other questions I just asked, so on our own part, it was from the neurosurgical plus ago that one of the consultants, microbiologists, just sent me a consult and where they were invited because their wounds were breaking down at the neurosurgical ward.
Okay.
And then most of the organisms especially were mostly Klebsiella, Pseudomonas aeruginosa. So when he told me, I now felt, okay, so we had to go to the neurosurgical ward together. I got him and our scientist who was in charge of where they do the culture and sensitivity and one of his residents. A lot of them didn't really come with any form of infection or any signs of infection before surgery. So what we had to inform the nurse in charge, this is what is happening. And then we're going to be coming to do some certain things which they agreed. So and then because so some of them come from the ICU,
Okay.
and then some of them pass through the theater before they are admitted into the neurosurgical ward. So when I thought of that, we had to meet the people that were in charge there. So we went through the records of the surgery that were done to taking swabs from the nurses and other healthcare workers we met randomly, even on the neurosurgical wards. Then we went to the neurosurgical suite. That's the theater where the surgery is usually unit, and the ICU did likewise. And I went as far as even checking some of their suction tubes because a lot of these patients were on suction. Yes, then we went ahead. I actually, and the other nurse that is working with me, we went ahead to do some form of trainings for them, especially with regards to standard precautions. And then we let them know these were the things we found.
Okay.
Because, yes, we let them know. And then some of the doctors we met, we communicated, and then the consultants said he was going to also talk to the other doctors since they have what now. Yes.
Yes, very important thing you did there, and I certainly do not doubt, or rather expect anything less. But specifically, I want you to speak on there is outbreak of Lassa in Plateau. So how
Yeah.
are you responding in Jute? What are you doing?
To do a training as emergency response for outbreaks, which I were able to train different health. Unfortunately, at that time, Joesu were on strike, and our supplies normally come from the store. So I have been going to the isolation unit, and for the training, we've not really had formally group. We had to do some trainings online with them, and then the physical ones for those who are there. And then they actually complained about supplies, especially because of this strike, which I was even there last week to find out what and what do they need, what and what do they have, and what they don't have, which meetings we had with the CMD, I pleaded so that they can
Right
just be
now,
supplied.
are there triage stations? Are you people checking the incoming and outgoing? I think if you pay attention to some of the things that to check about on what is coming in and what is going out.
Yes, for now, the IPC
You have
link
that
no
across the points.
come from. We have spoken to them. It's just unfortunate that we don't really have a triage station per se. It's just that when the patient comes to the ward, whether from the clinic, because it Lassa fever, and trying to let them know this is what they should do for each
Do
patient
you
that
have IEC materials that are placed strategically talking about Lassa?
no.
The facility working with the state.
I spoke to the IPC state focal person, I think last week, and then
Okay.
she said,
Did you make
okay,
a request for distance?
Ifeanyi, I think from NCDC, and he said he wanted to see how they
So-
were even in I don't want to
So
see how they can help.
the point is all these resources you can the public health structure in the state. And this is why I implore all of you as facility focal persons, you must look beyond the four walls of that your hospital. Certainly, and there are a lot of resources that exist at the level of the state, and they can that you reach out, extend that bridge or olive branch to them, talk with them, and be able to understand how you can work together. Because that facility you work at is actually in a state. Every health facility is in an LGA now. Is in a certain ward even, no matter how big the hospital is. And it is meant to cater for the population of. So it's really important that the teaching hospital in each state is seen as part and parcel of the public health structure in the state that can be leveraged. And the only way that can be done is through relationships. So folks in teaching hospital, please come off your heart to the colleagues at the state ministries of health. They do a lot, they know a lot, they can help you a lot. You can leverage their resources. And then importantly, they all. And that's, I think, it. Thank you very much, Tina, for the insight. Those people you mentioned are all resourceful and important to this outbreak response. So, Dr. John, I don't know if I am done. Hello? Dr. John?
Okay. So her network she was having issues with her network.
Oh, okay.
Yes. So at this point, I don't know if we have more questions or contributions from the participants. Okay. In the absence of that, thank you so much, Dr.
All right.
Muzaki.
Yes. Thank you very much.
We really, really appreciate the time that you have spent, such a very robust and insightful presentation today. Thank you. From the chat, I could see people saying thank you for the presentation. The session is being recorded for those who want us to share with them. Yes. Thank you everyone for participating. It's really been a very great and interesting section. Yes, let's say thank you in the chat. Yes, let's appreciate it our best emoji. Thank you, Dr. Muzamil. And we look forward to having everyone again in 2 weeks' time. We're going to be having a topic. Yes, someone is saying thank you. Yes, thank you so much. Yes, 4th of March, we'll be having HAI surveillance. We'll be having our amiable speaker, Dr. Fumi. Dr. Fumi will be part of the presentation. Yes, we'll be having her in 2 weeks. And I look forward to having everyone. Special thanks to AP for putting this together. I really enjoyed this section, and I want to believe that every one of us did enjoy. Yes, and we look forward to having us again. Thank you once again, Dr. Muzami. I understand that you have a very busy schedule, but you've been able to, take out time from your schedule to be with us today, and we really, really appreciate. I want to say thank you. So at this point, we draw our curtains.
Thank you, everybody.
Thank you. Good to have you. I look forward to having you again, 4th of March. Dr. Fumi will be taking the presentation on HAI surveillance. Thank you, everyone. And have a great afternoon ahead. Yes, have a great afternoon ahead.
All right,
Thank
thanks.
you. Bye-bye.
All right, bye.
Bye-bye.
Bye-bye.
Goodbye, everyone.
Goodbye.